Welcome to the deep dive. Today we're getting into lower extremity peripheral artery disease, PAD for short.
Right.
Now, it sounds like maybe just a blood flow issue, but it's actually, well, it's a whole range of conditions. Lots of treatment options, too.
Oh, it's really diverse.
Which means, for you listening, figuring things out, making good choices, it really needs everyone on the same page, you, your family, the medical team.
Absolutely. And it's interesting, even just defining PAD isn't totally straightforward.
Oh, how so?
Well, we often use this measurement, the Ankle Brachial Index, the ABI.
Right, yeah.
And we often say, zero point 0.9 or less means PAD, but it's not quite that simple.
Okay.
PAD can show up very differently. Some people, they have no symptoms at all. Others have terrible pain, even tissue damage.
So that 0.9 is a guide, but not the whole story.
Exactly. It's a common marker, sure, but you can have significant PAD before you hit that number, or maybe never hit it but still have issues. Relying just on the ABI has its limits.
Got it. Okay, so how common is this? Are we talking big numbers?
Oh, huge numbers globally. Back in 2010, the estimate was 202 million people worldwide.
Wow.
And what's really striking is that between 2000 and 2010, a lot of that increase, a really significant chunk, happened in low and middle income countries.
Why is that? What's driving that trend?
Well, it's likely a mix of things. You've got increased urbanization, lifestyle shifts,
Right.
leading to more risk factors like smoking, diabetes, obesity.
Makes sense.
Plus, maybe better detection, people living longer, so we're just identifying more cases.
And this connects to the number of procedures too, right?
Yeah.
More people needing interventions.
Definitely. As PAD prevalence goes up, so does the need for revascularization procedures to restore blood flow. Just look at the U.S. Medicare population.
Yeah.
Between 96 and 2006, lower extremity revascularizations jumped from about 357 per 100,000 people to 581. That's a big leap.
It really is. So with PAD presenting in so many ways and more procedures happening, managing it sounds complex.
Extremely complex. You're juggling so many variables.
What kind of things?
Well, the underlying cause, how bad the ischemia, the blood flow restriction actually is. Is there infection? What shape are the vessels in? Other health problems the patient has. Their activity level, their specific artery anatomy.
It's definitely not one size fits all.
Not at all. And that complexity is why we often split patients into two main buckets.
Okay.
You have those with intermittent claudication IC, that's the leg pain when walking.
Right.
And then you have those with chronic limb-threatening ischemia, or CLTI.
CLTI. I've heard critical limb ischemia before. Is that the same?
It used to be the common term, yeah.
Yeah.
But CLTI is preferred now. It better captures the severity that the limb is genuinely at risk.
And this distinction, IC versus CLTI, it's a really big deal, isn't it? More than just how much pain someone's in.
Oh, absolutely fundamental. Their natural histories, how the disease progresses without treatment, and our treatment goals are completely different.
How different are we talking?
Okay, so someone with IC, their risk of needing a major amputation over 5 years, it's actually pretty low, less than 5%.
Okay, that's reassuring.
But for CLTI, that risk jumps to around 30% within just 1 year.
30% in 1 year. Wow.
Yeah.
That really puts the urgency into perspective.
It absolutely does.
Yeah.
And it dictates why our approach has to be so different for each group.
Yeah, very different stakes involved.
And another crucial thing to remember is that PAD, whether it's IC or CLTI, it rarely happens in isolation.
Meaning other heart or circulation problems.
Exactly. These folks often have significant cardiovascular disease elsewhere, heart, brain, and sadly, the mortality rates reflect that.
How high are they?
Well, the 5-year all-cause mortality estimates, they're around 20% for IC, but jump to about 50% for CLTI.
50%. So the leg arteries are really a canary in the coal mine for overall cardiovascular health.
That's a great way to put it, a very strong marker.
So given those odds with CLTI, that high risk of losing the limb, it makes sense patients might consider riskier procedures.
Right. They're often willing to accept a higher risk intervention because the alternative, limb loss, is so devastating.
But for IC, the calculation is different.
It is. The immediate threat to the limb is much lower. So the threshold for doing an invasive procedure is higher. It's more about, okay, have we tried exercise? Have we tried medication? Is the claudication still really limiting their lifestyle? Then maybe we consider intervention.
But the goals are different. CLTI is about saving the limb, period.
Primarily, yes. Limb salvage is paramount.
Whereas IC is more about walking better, feeling better.
Exactly. Reducing that walking impairment, improving function, improving quality of life.
But despite those differences, one thing is constant, right? everyone with PAD needs medical management.
100%. Regardless of IC or CLTI, managing the underlying cardiovascular disease is critical for everyone.
And the main aim there is reducing the risk of heart attacks, stroke.
Precisely. Because PAD is a sign of systemic atherosclerosis, hardening of the arteries everywhere. So tackling those risk factors is non-negotiable.
And it's interesting, you mentioned the ABI earlier. Even if someone's below zero point 0.9 but feels fine, no symptoms, they still have significant PAD.
Yes. That's what we call chronic subclinical lower extremity ischemia. It affects more than half of people with an ABI below 0.90. The disease is there, even if you don't feel it.
But we don't typically do procedures on those people, right, if they have no symptoms?
Generally, no. The current evidence doesn't support revascularization just based on an abnormal ABI in an asymptomatic person.
So what's the point of even finding it then? Screening.
Well, the potential value there might be identifying those individuals who really need aggressive medical therapy.
To prevent future heart attacks and stroke.
Exactly. Catch them early, manage their risk factors intensely, prevent those major cardiovascular events down the road. That might be the real benefit of screening in asymptomatic folks.
So the focus becomes general prevention, stop smoking, obviously.
Absolutely critical.
And educating people about how PA can progress.
Yes. And the core medical management for all PAD patients, symptomatic or not, involves a few key things.
Okay, what are they?
Daily antiplatelet therapy, usually aspirin or clopidogrel, and daily statin therapy to lower LDL cholesterol.
Is there a specific target for the cholesterol?
Typically, the goal is LDL less than 100 mg/dL, but for people considered very high risk for cardiovascular events, we often aim even lower, maybe less than 70.
And other conditions? Blood pressure? Diabetes?
Gotta manage those too. Optimizing blood pressure, often using ACE inhibitors, and getting really good glucose control in diabetics are also crucial parts of the plan.
Okay. What about after someone has a procedure, say a stent or a bypass? Does the medication plan change?
Good question. That area is still evolving a bit, and we borrow a lot from cardiology practices.
Makes sense.
Generally, after any revascularization, whether it's endovascular or open surgery, patients need at least one antiplatelet drug.
To prevent clots in the treated area.
Exactly. Now, whether adding a second antiplatelet like a clopidogrel to aspirin dual antiplatelet therapy or DAPT provides extra benefit,
Right.
the results there have been kind of mixed.
Mixed how?
Well, you might get some added protection against clotting, but you also definitely increase the risk of bleeding. So it's a trade-off. And the evidence isn't universally strong for routine DAPT long-term after all PAD procedures.
I remember reading about maybe using a blood thinner like an anticoagulant.
Yes, that's a more recent development. There was a major trial looking at adding a low dose of rivaroxaban, which is a direct oral anticoagulant, to aspirin after lower extremity revascularization.
What did it find?
It suggested that this combination was actually more effective than aspirin alone in preventing a composite of bad outcomes, things like worsening limb ischemia, major amputation, heart attack, stroke, or cardiovascular death.
So that's promising.
It is promising, but it's still relatively new. We're still figuring out exactly how best to use it and in which patients. Plus, again, you have to balance that benefit against the bleeding risk.
Okay. Let's switch gears a bit. Exercise therapy for claudication. It sounds almost too simple, but I hear the evidence is strong.
It's incredibly strong. Honestly, numerous reports, more than 20 randomized trials, they all point to supervised exercise training as the best initial treatment for intermittent claudication.
Really? Better than meds or procedures initially?
For improving walking distance and function, yes. Patients in these programs show significant gains in how far they can walk without pain, their overall walking performance.
And I imagine there are other benefits too, beyond just the legs.
Oh, definitely. Regular aerobic exercise does wonders for cardiovascular health overall. Lowers cholesterol, lowers blood pressure, improves blood sugar control.
Right.
And think about it with claudication, the pain makes you less active. That leads to deconditioning, which is bad for your heart anyway. Exercise breaks that cycle.
So what do the guidelines actually recommend for an exercise program?
The ACCHA guidelines give it a strong recommendation. They suggest supervised sessions, minimum 30-45 minutes, 3 or 4 times a week, for at least 12 weeks.
And what do you do in the sessions?
The basic idea is walk until you hit that moderate claudication pain. Rest until it goes away, then walk again. Repeat.
Pushing through the pain, essentially.
Pushing to the pain, then resting, then repeating. As you get fitter, you gradually increase the intensity or duration. It's about progressively challenging yourself safely.
Sounds effective, but I can see how sticking with that might be tough. Compliance must be an issue.
It's a huge issue. You're absolutely right. Clinic-based supervised programs tend to work better than just telling someone to walk at home.
Why is that? The structure? Accountability?
Probably all of the above: structure, support, supervision. Home-based programs can be effective, especially if you add behavioral techniques to boost motivation.
But still, not everyone can do it.
Exactly. Many patients just can't participate due to other health problems, or they simply refuse. And even though Medicare now covers supervised exercise therapy for claudication, practical things like getting to the clinic can be barriers.
So it helps the people who do it, but not everyone gets to do it.
That's the reality. It ends up benefiting only a fraction of claudication patients, even though it's technically the best first step for many.
Is technology helping here? Like fitness trackers or apps?
There's definitely active investigation into that, using activity trackers, telehealth apps. The SVS even piloted something with CELD. The hope is these tools can make at-home exercise more engaging, provide support, and improve adherence.
Makes sense. Okay, what about medication specifically for the claudication pain itself?
Yeah.
Besides the antiplatelets and statins?
Yeah, so there's been research for over 30 years looking for drugs to help claudication. Lots of things investigated: drugs affecting tissue metabolism, nitric oxide, vasodilators.
Any winners?
Well, in U.S. practice today, really only one medication is commonly used specifically for claudication symptoms, and that's Cilostazol.
Cilostazol, how does that work?
It's a phosphodiesterase third inhibitor. Basically, it increases levels of something called camplion inside cells.
And what does that do?
A few things. It helps relax the smooth muscle and blood vessel walls, improving blood flow. It also inhibits platelets from clumping together, so it has an anti-clotting effect. And it seems to have some beneficial effects on lipids, too.
So better flow, less clotting.
Probably a combination of those things leads to the improvement in walking. We don't know the exact mechanism for symptom relief, but it works.
And the evidence shows it works.
Yes, pretty consistently. Controlled trials, meta-analyses, they confirm Cilostazol increases walking distance, often by up to 50%, and improves quality of life scores.
50% is quite a jump.
It can be significant for some patients. There's even some evidence, quite interesting actually, that it might stimulate angiogenesis, the growth of new small blood vessels, by affecting VEGF production in ischemic limbs.
Wow. New blood vessels. How does it stack up against other drugs that were tried, like pentoxifylline? I think I remember that one.
Yeah, pentoxifylline was used for a while. The Dawson study directly compared Cilostazol to pentoxifylline. Cilostazol came out significantly better for increasing walking distance. In that study, pentoxifylline was basically no different from placebo.
So Cilostazol is the main pharmacologic option for symptoms.
Pretty much. Pooled analyses show its benefit over placebo is sustained for at least 6 months.
Any downsides? Side effects? Who shouldn't take it?
Like any drug, yes. Common side effects are usually moderate headache, diarrhea, some GI upset.
Okay.
The big contraindication is congestive heart failure. It should not be used in those patients. And because it's metabolized by the liver's P450 system, you have to watch out for drug interactions.
Right. Always need to check the full med list.
Always.
Okay, so we've covered medical management pretty thoroughly. Let's move into that trickier area, deciding about revascularization, about procedures to open up the arteries. You said earlier there's rarely just one right answer.
That's probably the most important takeaway. It's almost never black and white.
Even with classification systems. I know there are things like GLASS and TASC that look at the anatomy.
Those systems, yeah, they offer some guidance. They help categorize the anatomic pattern of disease, which can suggest if endovascular, catheter-based treatment or open surgery might be technically easier or more likely to last.
But that's just one piece.
Exactly. It's just one piece of a much larger puzzle. Making the right call requires a really sophisticated understanding of so many different facets.
Like what?
Well, the patient's overall health, the specifics of their PAD, what procedures are even possible, the risks involved with each, the potential benefits, and crucially, communicating all that clearly to you, the patient, and your family.
And so everyone can make a decision together.
That's the goal, patient-centered decision-making. And the process looks different depending on whether we're talking about IC or CLTI.
Because the goals are different. IC is about walking and quality of life.
Right. Reduce walking impairment, improve function, improve QOL.
While CLTI is about saving the limb.
Primarily, yes, reduce the risk of limb loss. So naturally, the tolerance for procedural risk is going to be different.
That makes total sense. And you also mentioned that technical success opening the artery isn't always clinical success.
Critically important point. Just because we got the vessel open on the angiogram doesn't mean the patient is actually better off.
So how do we define success then?
We have to define it up front for each individual patient. What are we trying to achieve here? Beyond just improving blood flow, which is the general goal, what does success look like for this person?
And it starts with knowing if it's IC or CLTI.
Absolutely. First, categorize the disease. Then, communicate the prognosis realistically, what's likely to happen with or without intervention.
Traditionally, success might have been measured by how long a stent stays open or a bypass graft.
Exactly. We used to focus heavily on graft patency, stent patency. But we've learned that doesn't always correlate with what matters most to the patient.
How so?
Well, Simons and colleagues found that even among CLTI patients whose bypass grafts were still open a year later, a good chunk of them hadn't actually seen a meaningful clinical improvement in their limb.
So the plumbing was working, but the patient wasn't better.
Essentially, yes, which is why the focus has shifted towards limb and patient-centered outcomes.
Okay. What falls under that umbrella?
Things like survival, obviously. Amputation-free survival, being alive without a major amputation. And increasingly, freedom from needing more procedures, freedom from reintervention.
Because every extra procedure is a burden.
Exactly. Physically, emotionally, financially. The SVS objective performance goals reflect this, emphasizing major adverse limb events, which includes both amputation and the need for repeat revascularizations.
Okay, so for claudication, where the goal is walking and QL, how do we measure success there? Patency seems less relevant.
Precisely. Procedural endpoints like patency don't really capture why we intervene in the first place. If we do revascularization for claudication after exercise and meds haven't been enough, success has to be measured by improvements in physical function and quality of life.
Can procedures actually achieve that for claudication?
Yes, in many cases. Taylor and colleagues found that about 80% of carefully selected claudication patients had symptomatic improvement after revascularization, with a very low risk of limb loss.
So it's not always needed, but it can help quality of life.
Definitely. And this is why patient-reported outcomes, PROs, are becoming so important. Using standardized surveys like the Vascular or EuroQL lets us measure the impact from your perspective. European registries and the U.S. Portrait Registry are already incorporating these.
And for CLTI, where saving the limb is key. Is that the only measure of success?
It's the simplest definition, sure, limb salvage, but the goals are often more complex and patient-specific.
Like what?
Well, think about that study by Taylor again, when they looked at a combination of outcomes for CLTI, bypass patency, plus limb salvage, plus being able to walk, plus survival. Only 44% of patients achieved clinical success across all those domains.
Only 44%? That's sobering.
It is. It highlights that certain factors really predict failure. Things like being unable to walk well beforehand, end-stage kidney disease, having gangrene already, disease below the groin.
And the more of those factors someone has,
the lower their probability of a truly successful outcome plummets. Which brings us back to needing really careful patient selection, risk stratification, and honest counseling.
and sometimes amputation might be the best path.
In some cases, yes. If the risks of revascularization are very high and the chance of a good functional outcome is very low, primary amputation might offer the best way to manage pain, deal with infection, and potentially improve overall quality of life faster. It's a tough conversation, but a necessary one sometimes.
Okay, let's talk guidelines based on presentation. Starting with intermittent claudication, the initial approach seems pretty clear.
Yes, the ACAA data really drives this. For AC, the risk of major amputation is low, maybe 1% per year.
But the heart attack stroke risk is higher.
Much higher, 3 or 5% per year. So step 1 is always cardiovascular risk factor modification and medical therapy.
Smoking cessation, exercise, antiplatelets, statins, maybe Cilostazol.
Exactly. Exercise is key. Cilostazol can help symptoms in addition to the antiplatelets. Revascularization is really reserved for severe lifestyle-limiting claudication after those medical therapies haven't provided enough relief.
What about smoking cessation, specifically for the leg pain? Does quitting help the claudication itself?
The evidence there is a bit unclear, actually. Some studies suggest it might improve walking distance, others don't show a strong direct link.
But it's still crucial for overall health.
Undisputed benefit in reducing cardiovascular events and slowing atherosclerosis progression everywhere. So absolutely critical, even if the direct effect on claudication symptoms is debatable.
And Cilostazol, the guidelines support its use.
Yes, ACSA recommend it as an effective pharmacologic option for improving ambulation in claudicants on top of their antiplatelet therapy.
Now, comparing that medical approach to going straight to endovascular therapy for claudication, what do the big trials show?
Well, the Edinburgh Walking Study compared angioplast stenting to medical management. They found no significant difference in walking distance improvement or quality of life between the groups.
No difference. Interesting.
And then the Clever trial looked specifically at aortoiliac disease. It compared supervised exercise versus stenting versus optimal medical therapy.
And the winner was
Supervised exercise actually showed the greatest improvement in peak walking time.
better than stenting.
Better than stenting or drugs alone for walking time, yes. Though both exercise and stenting did improve quality of life more than just the medications in that trial.
So overall, the risk-benefit for claudication generally favors trying medical therapy first.
Generally, yes. Lower initial risk,
Yeah.
but it's only really effective in maybe 30% of patients.
So for the other 70%, if symptoms are bad enough, revascularization is on the table.
Right.
And endovascular is usually preferred over open surgery.
Typically, yes, because of the lower morbidity and mortality, lower immediate risk when it's anatomically feasible.
But you mentioned potential downsides, like maybe needing bypass later anyway.
Yes, there's that potential treatment trap idea, an increase in bypasses for claudication after failed endo attempts. And although rare, the risk of amputation after a claudication procedure, while low, is devastating.
So managing expectations is key.
Crucial. You have to weigh the risks, the benefits, and have a realistic discussion about how much improvement the patient can truly expect in their symptoms and quality of life.
And the decision between endo and open for claudication anatomy is a big driver.
A huge driver. The relatively benign natural history of claudication usually doesn't justify the higher risks of open surgery if a less invasive endovascular option is likely to work.
But you cautioned against thinking endo doesn't burn bridges.
Right. It's not always a completely free shot. Anatomy really dictates durability. Johnston and others showed that focal blockages, short segments in big arteries like the common iliac with good outflow, especially in non-diabetics, those do great long-term with angioplasty.
Prime example for endo.
Exactly. But contrast that with a long, completely blocked superficial femoral artery in the thigh. Open bypass might last much longer there.
And diffuse disease. Blockages everywhere.
That's the real challenge, and it's more typical of CLTI patients. Much harder decision.
Okay, let's pivot Philly to CLTI now. Less common than IC, you said, but uses more resources and has a much worse outlook.
Definitely. It consumes the lion's share of treatment resources, and the prognosis is grim. Roughly 25% risk of major amputation within a year, and sadly, about a 25% risk of cardiovascular death within that same year.
So for CLTI, revascularization is almost always considered, unlike IC.
Yes. In functional patients with CLTI, revascularization is always considered the primary approach over just medical therapy and exercise. The limb is actively threatened.
But medical therapy can play a role, especially with wound care.
It can. Specialized wound care centers using modern methods have shown decent healing rates for ischemic ulcers, maybe around 55%.
Not that bad.
It's not, but healing can be slow, unpredictable, and importantly, routine use of things like prostanoids, vasodilators, even hyperbaric oxygen, none have consistently proven beneficial for healing these ulcers.
So revascularization is really essential for CLTI.
It's the cornerstone. Medical therapy manages risk factors, wound care is supportive, but restoring blood flow is paramount. Intensive wound care alone might be an option in rare cases of truly unreconstructible disease with superficial ulcers, or perhaps for palliation in very high-risk end-of-life situations.
Which brings us to that difficult choice. Limb amputation versus trying to revascularize for CLTI.
Yeah. Revascularization is usually preferred, definitely the goal, but primary amputation is still necessary in maybe 10–40% of CLTI cases.
Why so high?
Usually due to overwhelming infection that can't be controlled, or the disease is simply too extensive, unreconstructible. And interestingly, unreconstructible disease is also behind nearly 60% of secondary amputations, those that happen after a revascularization attempt fails.
You mentioned earlier, counterintuitively, amputation can sometimes lead to good quality of life.
It absolutely can, and it's important patients understand this. Especially with below-knee amputations in younger, otherwise reasonably healthy individuals, prosthetic rehab can lead to high rates of maintained walking and independence.
So it's not always a failure.
It shouldn't always be seen that way. It can be a reconstructive choice to restore function. We even have prediction models, like the Diamond model, to help estimate post-amputation walking potential. Techniques like immediate postoperative prosthesis, IPOP, can speed up healing and return to ambulation too.
But for very frail patients with lots of tissue loss.
Then a primary above-knee amputation might be considered for palliative reasons, pain control, Wound management, when the patient is unlikely to benefit from a complex revascularization. Judging that is tough, though.
How do you judge?
Taylor's work again showed that preoperative functional status is the most critical predictor of postoperative functional outcome after any CLTI intervention. That suggests there's a subset of patients whose pre-existing frailty makes primary amputation a potentially better path to improved quality of life, even if technically the limb could be saved.
Okay, let's dive into the big debate for CLTI. Endovascular versus open surgery. What's the thinking?
Well, traditionally, open bypass was often favored for CLTI because the disease is typically multi-level, complex,
Right.
maybe less amenable to percutaneous fixes based on older classification systems like TASI.
And the argument for open surgery is,
Better patency, more durable results long-term. That's the main pro.
Thanks.
Higher upfront risk perioperative morbidity and mortality, longer hospital stays, need for ongoing graft surveillance, potential for reinterventions on the graft, and critically, you need a good vein to use as the bypass conduit.
okay, and the argument for endovascular and CLTI.
Lower immediate risk, less invasive, often outpatient. Proponents argue that even if patency isn't as durable, restenosis, the artery narrowing, again rarely prevents you from doing surgery later if needed.
But you mentioned that might not be entirely true, that prior endo could affect later surgery.
Exactly. Data from Basel and other studies like Nolan's suggest prior ipsilateral same-leg endovascular intervention might actually worsen outcomes for a subsequent bypass. Lower amputation-free survival, higher amputation rates, higher graft occlusion. It definitely challenges that free shot idea.
So the conduit, the vein for bypass, is a huge factor.
Massive. Great saphenous vein is king because it lasts the longest. If you don't have a good one available, endovascular becomes much more attractive.
Can other veins be used?
Yes, surgeons can use alternative autogenous veins, sometimes prosthetic grafts, but mapping the veins with ultrasound before doing an arteriogram is crucial. It heavily influences the strategy.
So with all these pros and cons,
Mm-hmm.
what is the best evidence the randomized trials say about endo versus open for CLTI?
That's where it gets frustrating. We lack definitive high-level evidence. The UK's Basel study is one of the few big ones. Compared angioplasty versus bypass.
Results.
Amputation-free survival was similar at 6 months, but at 2 years, bypass seemed to have an edge. What was really striking was the high crossover rate patients switching groups over time.
Suggesting they're complementary.
Exactly, not necessarily either. And it highlights the need for vascular specialists skilled in both open and endovascular techniques.
Thankfully, more trials are ongoing. Basel 2, best CLI.
Yes, precisely. Basel 2 is looking at vein bypass first versus best endo first. Best CLI in the US is comparing best open versus best endo head-to-head. We're all eagerly awaiting those results to hopefully get clearer answers.
You mentioned the WIFI classification system earlier.
Yeah.
How does that fit in? It sounds more comprehensive.
It is. The SVS WIFI system, wound, ischemia, foot infection, was developed because limb threat isn't just about PAD, especially with diabetes involved. It grades each of those 3 components.
Wound, ischemia, infection.
Right. Each gets a grade 0 to 3 based on severity. Combining those grades puts the limb into a clinical stage 1 to 4, which strongly correlates with the 1-year risk of amputation. It's been validated multiple times and helps standardize how we assess limb risk across different causes.
And the global vascular guidelines build on this, using PLAN.
Exactly. The Global Vascular Guidelines for CLTI management promote a holistic, patient-centered approach using PLAN, patient risk estimation, limb staging using WIFI, and anatomic pattern of disease using GLS.
Patient risk first.
They emphasize patient risk as the most important factor. Are they a candidate for limb salvage? What's their perioperative risk? Life expectancy. Simons's model helps predict this.
Like WIFI for limb staging.
Yes, with a note that maybe stage 1 WIFI, very low risk, might not benefit much from revascularization.
And GLAS for anatomy.
Right. The Global Anatomic Staging System. It's clinically driven, focuses on target artery flow needed for healing, and integrates factors relevant to both open and endo success. The PLAN algorithm ties patient risk, limb stage, and anatomic pattern together to guide evidence-based choices.
Are there other risk models besides these guidelines?
Yes, quite a few. They use statistical modeling on large data sets to identify predictors for specific outcomes like survival or AFS at certain time points. They generate risk scores.
Useful.
Can be very useful for counseling and decision-making, but you have to use them correctly. They're usually specific to certain outcomes and timeframes. They complement clinical judgment. They don't replace it.
Finally, cost. Always a factor. How does that play into PA treatment?
Increasingly important. Healthcare financial pressures mean we're looking more at who to treat, not just how. Cost effectiveness data is a bit mixed right now.
Revascularization versus amputation.
Generally, revascularization for CLTI seems cost-effective compared to primary amputation with prosthetic rehab, because rehab is expensive long-term. Primary amputation might be cheaper if the patient forgoes extensive rehab.
So it depends on rehab potential.
A lot hinges on that, yes, which often links back to their preoperative functional status.
And for claudication, cost-effectiveness data.
We really lack good comparative effectiveness data for claudication using relevant endpoints like patient-reported outcomes. Those will likely become required. We need to figure out the most cost-effective single treatment or sequence for both IC and CLTI.
So summing up, still some big unmet needs.
Definitely. We need more definitive high-level evidence on both clinical and cost-effectiveness. Treatment right now remains highly individualized based on the patient, the disease pattern, the risk.
But some general principles hold.
Yes. Endo often makes sense for much aortoiliac disease. Bypass remains a durable option for severe aortoiliac and infrainguinal disease in good candidates with good veins. Endo might be preferred for patients with shorter life expectancy, no good vein, high surgical risk, or less severe blockages. Primary amputation or palliation for those with unreconstructible disease or overwhelming comorbidities.
But clean comparisons are tough.
Extremely tough with so many variables. That's why Basel II and Best CLI are so important. And payers are increasingly demanding evidence-based care. Quality metrics matter more.
And maybe future medical breakthroughs.
That's the hope. Genomics, angiogenesis therapies, stem cells. Maybe someday these will reduce the need for interventions or make them work even better.
This has been incredibly informative, a real deep dive into a complex area. Thank you so much for breaking it all down.
My pleasure. It's a challenging field, but crucial to understand.
And thank you all for joining us for this deep dive. We'll catch you on the next exploration.